Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Let's get started. My name is Steve Palmer, LE&RN's Media Director, and I have the privilege of introducing today's speaker, Dr. Siba Haykal. Dr. Haykal is the Section Chief of Reconstructive Oncology for the Division of Plastic Surgery and Reconstructive Surgery at Yale School of Medicine. She's a double board certified plastic and reconstructive surgeon. She is an acclaimed specialist in microsurgical reconstruction and has research interests in breast reconstructive surgery and vascularized composite allotransplantation. Dr. Haykal has years of experience delivering care for breast cancer patients. She specializes in autologous-based reconstruction. She offers innovative techniques for restoration of breast sensation and immediate lymphatic construction following lymph node dissection. She has extensive experience in treating lymphedema and offers lymphovenous bypass and lymph node transplantation. Dr. Haykal also offers microsurgical treatment for skin cancers, head and neck cancers, and sarcomas. Without further ado, I turn it over to you, Dr. Haykal.
Thank you so much for the great introduction. I'll just begin by sharing my slides. So I'll be discussing clinical research in robotic lymphedema surgery. Thank you for the introduction. My disclosures are that I'm a consultant for MMI. So we'll be dividing this webinar by looking at what are the surgical options for lymphedema and the role of robotic surgery. I'll also discuss my case experience at Yale with robotic-assisted lymphedema surgery, and I'll give an overview of the precise clinical trial. So let's begin with surgical treatment options for lymphedema and the role of robotic assistance. Let's understand lymphedema first. So lymphedema affects up to 250 million people worldwide. It is the unseen epidemic. In the United States alone, there's about 10 million individuals that live with lymphedema, more than those affected by HIV, Parkinson's, multiple sclerosis, muscular dystrophy, and ALS combined. Very frequently, it is a side of cancer treatment, particularly after surgery and radiation. And despite how prevalent it is and the impact of lymphedema, most patients are only offered therapies that really address their symptoms, but really we do not look at the underlying lymphatic dysfunction. What is the impact of lymphedema and its complications? So physical impact. It can lead to infections, to wounds, to limited mobility. It can lead to emotional distress. It can lead to economic impact, such as work loss. There's a lot of out-of-pocket expenses for treatment and for durable medical equipment, and there's a lot of travel costs as well. And patients often express frustration with the fact that it is incurable and a lifelong disease. They say that it is very time-consuming, and very often there's a lack of understanding of lymphatic disorders by many clinicians. In a recent NIH report, there was a discussion of the importance of lymphatics in both health and disease. So back in September of 2022, the NIH convened and they wanted to spotlight the lymphatic system and its role in health and disease, and to really identify gaps and opportunities. Lymphatic system dysfunction is linked to many diseases, including neurological diseases, cardiovascular disease, renal disease, and autoimmune conditions. And there's a lot of technology such as single cell analysis, imaging, and computational tools that are really helping researchers try to better understand and study the lymphatic system. The people who were present at this NIH workshop really emphasized the urgent need for imaging, for functional assessment, and for surgical innovation, such as lymphovenous bypass and lymph node transplantation to improve outcomes for patients with lymphatic disease. The patient's journey from diagnosis really comes with a lot of frustration, limited solution. There's really no real resolution. And additionally, it requires a lot of personal funding to relieve pain, swelling, and lymph volume. So this includes compression, massage, which is a repeated cycle, and it is quite costly treatment for life. What are the clinical benefits and value of surgical intervention? So in terms of surgery, there's multiple modalities available. I'll be talking about two of them that are really microvascular related, which is a lot of the bulk of a lot of the work that I do. But what they can help do is reduce lymph swelling and pain. They can lower the risk of recurrent infections. They improve mobility and quality of life, and they can alleviate associated comorbidities such as depression, anxiety, and fatigue. These overall lead to lifelong cost savings. They reduce hospitalization, infections, and disability-related expenses. However, there aren't many surgeons across the world that are trained to work on lymphatic vessels. Often these vessels are less than 0.5 millimeter in size, and they require they require super microsurgery, so they require extensive training. Let's talk about lymphovenous bypass. This is a really specialized technique, and I'll show you the video in a little bit, where we bring in a microscope and under visual magnification, we dissect these lymphatic vessels that are very small. They can be about 0.5 millimeters and even smaller. And these are very delicate structures. And we try to bypass them into veins. That's a lymphovenous bypass. So typically we bring these vessels are a piece of rice is about 2 millimeters in size. The end of a pencil is about 1 millimeter. And frequently the size that we put together is 0.5 and less. So we definitely use this as a technique. So in this video here, you can see that these sutures that we use are finer than a hair. So they're very difficult to see under the naked eye. So we use a microscope to do that. And what they're doing here is they are bypassing, they're putting an end of a lymphatic into a vein. And the goal is to bypass the lymphatic fluid into the vein. So let's talk about the robotic technology. So this new robotic technology can really help address the challenges of lymphedema surgery. As we talked about, these vessels are very, very small, and they're very difficult to put together, even using a microscope. So is there something that can actually help us do that? So this is an example of a video that shows Dr. Robert Van that's performing a robotic-assisted lymphovenous bypass with the Samani robot for breast cancer-related lymphedema, and this was done in Hackensack University Medical Center in New Jersey. And if you look at the difference between manual anastomosis and robotic anastomosis, it's been shown that with robotic anastomosis, there's a reduction in the tremor while using the robot in comparison to doing this manually. So that becomes very important for efficiency and in order to perform the surgery safely, as we can frequently, you can tear those vessels and they're very small and they're very delicate. So expanding access to super microsurgery is very important. The Samani surgical system enables trained surgeons to perform procedures on lymphatic vessels that are smaller than 0.5 millimeters and allows for precision and consistency. So this is quite a shift because it reduces the learning curve and the physical limitations that have been historically restricted surgeons from being able to do this. And with the Samani system, more lymphedema patients can have access. There is potentially new surgical treatment options for them that were previously not an option. It will allow to alleviate the symptoms and improve quality of life, and to really standardize and to improve their clinical outcomes. And I'll talk about some of our experiences at Yale. But before that, I want to show you some of the studies that have been done around the world. So they've shown that there's a positive long-term outcomes in robotic-assisted lymphedema surgery. So one of the largest patient databases with long-term follow-up really demonstrates positive outcomes in supramicrosurgery. This was published by the group at the University of Zurich by Dr. Nicole Lindenblatt, where they performed over 100 anastomosis in 67 patients in a range of about 3 years. They focused mainly on lower extremity reconstruction, and they did it in patients who had primary lymphedema, so with a genetic background, or they were either born with lymphedema or developed it later with unknown cause, and secondary lymphedema, secondary to cancer and other reasons. And the data really showed that in the first 100 anastomoses using the robot, there were excellent outcomes and good patient satisfaction. So importantly, the follow-up was long, and in about 10 months after follow-up, there was about 86% in reduction of the limb volume for the upper extremity and 72% for the lower extremity. There were no anastomosis-related complications, and patients had an improvement of the lymphedema symptoms with volume reduction observed in the limbs. So for the people who are physicians and surgeons online, we now have worked quite hard at making sure that this lymphovenous bypass procedure, including robotic assisted, effective as of January this year, there's a new CPT code for this bypass, including robotic assistant when performed in any extremity. And the global lymphedema burden continues to grow. There's rising cancer survivorship. There's increased awareness of the lymphatic health, and patients are demanding for a better cure, not just palliative, but really solutions. So this is quite important because it allows people, more surgeons, to bill for these procedures and to make sure the patients have a good outcome. So I want to talk about our case experience with robotic surgery at Yale, and I'll talk about how we managed to start this and also about our learning curve. So I will be quite detailed in terms of the things that we've learned and how we hope to make things better. This is a study that we recently presented at one of the microsurgical meetings. This is a cohort study. So in this study, we actually compared robotic-assisted microvascular surgery with our controls, so without the robot. So as an FYI in background, the Samani has been approved by the FDA. This was granted its first clinical application in the US in April 9th of 2024. We have worked very hard to bring it at Yale. It's one of the few centers in the US that offers robotic-assisted microsurgery. And currently, we wanted to really look at clinical data on safety, on performance, on operative efficiency, because a lot of these studies were lacking in the reconstructive settings. So the objectives of our study was to assess the intraoperative efficiency of robotic-assisted microsurgery and to evaluate whether these postoperative outcomes and complication rates were different compared to regular or without using the robot. So this was a single center retrospective cohort with prospectively maintained databases. We looked at the robotic cohort, which we used the Samani surgical system, was employed for at least one suture for the microvascular anastomosis. And we looked at the manual cohort, where there were procedures that were performed exclusively using standard microsurgical instruments with a microscope. We looked at 3 different groups: the free flap group, so that's breast reconstruction with a deep inferior epigastric pedicle the MS sham. We looked at the second group, which is the lymphovenous bypass group. So that's a lymphovenous anastomosis for treatment of existing lymphedema. And we looked at the immediate lymphatic reconstruction group. So that's a lymphovenous anastomosis for prevention of lymphedema. So in the context of axillary lymph node dissection or groin dissection. So the patients, in a period of about 1 year, the patients who had microsurgical reconstruction were about 118. The robotic, we had about 36 patients. And in the manual anastomosis, we had about 82. And in the robotic, there was we had 33% had a breast reconstruction, about almost 53% had an immediate lymphatic reconstruction, and 14% had lymphovenous bypass. And in the manual anastomosis, we had 78% for breast reconstruction, 22% for immediate lymphatic reconstruction, and none for LVB. So we started the study basically as soon as we introduced the robot into our practice, we started comparing them to manual anastomosis. In terms of demographics and baseline clinical characteristics, the demographics, the comorbidities, and the treatment histories were comparable between robotic and manual cohorts across all procedure types. Manual procedures were followed for a significantly longer period across all categories for obvious reasons. And when we looked at operative and postoperative outcomes for the free flap cohort, there was no significant difference in reconstruction timing, in laterality, and postoperative outcomes between robotic and manual. And if we looked at the median procedure length, we trended towards longer for robot cases, but it didn't reach statistical significance. And this is obviously important because we had just started using the robot, so you can expect that there's going to be a learning curve when we start. When we looked at the free flap cohort and we looked at either anastomotic revisions, robotically or manual, what we noticed is that there was initially a revision rate that tended to be higher in the robotic group. This was not statistically significant, but again, there's always a little bit of a learning curve when we're starting to use any new innovation or tool. Importantly, things that we looked at were a small tear versus a leak. And those are the revisions really done for technical reasons, but they were not statistically different. Now, when we looked at the immediate lymphatic reconstruction cohort, so this is the cohort of patients that were having this done for preventative reasons. There was no significant difference in laterality and procedure length and hospital stay. There was the distribution of postoperative complications varied a little bit, and I'll talk a little bit about that. So what was interesting is that there was no revision in the robotic for any of the anastomosis, as opposed to the manual lymphatic. When we used the robot manually without the robot, we actually did revise some lymphatic anastomoses, but without the robot, we did not. And then when we looked at the immediate lymphatic reconstruction with no other procedures, meaning the patients were not also getting a breast reconstruction, for example, the complications were very rare and they were comparable between groups. So the robotic operations, however, were slightly longer, and that was significant. It's also as expected. We're trying to bring in a robot into the area. There's a learning curve in terms of setup. So generally, the procedures were a little bit longer. So how much longer, and can we look at predictors of procedure length? So when there was a reconstruction without another procedure, meaning without another type of reconstruction, such as a breast reconstruction, there was about a 39-minute reduction in operative time. But the manual approach basically was about 42 minutes shorter than the robotic, which is, in the grand scheme of things, it is fairly minor in terms of the length of procedure that it would take. And then obviously when there was a bilateral procedure, for example, when we're trying to do microvascular anastomosis on both sides, then it was slightly longer in terms of minutes. As expected, again, we're trying to bring in a new instrument, and there's a bit of a learning curve. And then when we looked at the immediate lymphatic cohort, the reconstruction, again, it was about 42 minutes shorter than with the robot. So the robotic, interestingly, some surgeons were using the robot for very specific reasons. Some were using it for all cases. Others were using it for lymphatic surgery only. And some were using it for microvascular anastomosis of larger vessels, such as an RA only. So their utilization in our group actually varied considerably among 4 surgeons. And what was more important is that the learning curve of each surgeon actually improved quite quickly. So eventually the anastomotic time with the robot actually got much faster and was better. And obviously we always try to compare it to the manual. And in some instances, for example, the lymphatic surgery, we're actually much faster with the robot now than we would be without the robot. For the arterial procedures, we're trending towards it being of similar length. We still continue to be faster with the manual surgery. So there was depending on the more you use it, the faster you become. That's sort of the trend that we started seeing. So our conclusions from our portion of the study and some of our work is that robotic-assisted microsurgery is safe and it's feasible. We have comparable complication profiles between robotic and manual cohorts across free flaps and immediate lymphatic reconstruction. Surgeons show variable adoption patterns, and they all have favorable learning curves. So there's a rapid attainment of proficiency across surgeons that really highlights its accessibility with appropriate training. However, there is a variation in adoption patterns, which really highlights that the surgeons can really tailor robotic use for the procedures and the workflow that they prefer. But all in all, there was operative efficiency could improve with workflow optimization. We've noticed there's a decrease in time of anastomosis over time, and we continue to try to optimize. So that's our cohort at Yale. Now I want to discuss one of the clinical trials that is happening in the US that involves more than one center. That's called the PRECISE trial, and I'll give you an overview of what this clinical trial entails. So PRECISE is a post-market real-world experience. It's expanding access to care by incorporating the Samani surgical system and enabling surgeons. I'm not sure if you'll remember that, but we'll just call it the PRECISE, but that's what it stands for. So the objective of the study was to really evaluate the Samani system's safety and effectiveness for microvascular anastomosis during free tissue transfer surgery and lymphovenous anastomosis. And the patients selected for the PRECISE study will be adults with a clinical indication for a microsurgical anastomosis of vessels between 0.1 millimeter and 2.5 millimeter in conjunction with open free flap surgery of the breast, the mouth, meaning head and neck, scalp, extremities, and or lymphovenous anastomosis surgery of the extremities. So this is a post-market study that is going to run across 15 sites, and the estimated duration is about 28 months. So the sites are up to 15 hospitals. The cohorts that we're looking for are free tissue transfers, so free flap for reconstruction. Up to about 281 participants would be included in the study. And for lymphovenous bypass, up to 174 participants. The follow-up is about 30 days for the free flaps and about 3 months for the lymphovenous bypass. The primary endpoints are intraoperative anastomotic patency and freedom from device-related safety adverse events. So the secondary endpoints are free flap survival and ischemia time. And for the lymphatic lymphovenous bypass, it's quality of life and lymph volume. And other things that we're exploring as exploratory endpoints are the number of robotic and manual sutures and the anastomotic suture time. So this is an important study because it will allow to enable the advancement of lymphedema treatment. It's the largest prospective multi-center study on free flap tissue transfer and lymphovenous bypass ever conducted. This is an opportunity to contribute to a monumental advancement in the field of microsurgery and lymphedema surgery. So who are we including? So to be eligible to participate in the study, individuals must meet the following criteria. They have to be at least 22 years of age. They have to agree to participate in the study, to return for all required follow-ups, to complete all study procedures, and to be able to willingly provide informed consent after receiving all the information related to the study, the requirements, and the robotic-assisted procedure. And patients that have a clear indication for microvascular anastomosis of vessels that are 0.1 to 2.5 millimeters in conjunction with open free flap surgery of the areas that we talked about. And obviously the investigators need to deem them candidates for free tissue transfer surgery and or lymphovenous bypass with a robot in accordance to the Simani system. Preoperative inclusion criteria. For the lymphovenous anastomotic cohort, it requires a swelling of one limb that is not completely reversed by elevation or compression, stage 1 or stage 2 lymphedema at screening based on the International Society of Lymphology staging system, at least one of the following postoperative quantitative measurements, so whether that's a volume differential between the affected limb and the contralateral limb must be at least 10% of the other, or bioimpedance, that's the LDEX using the SOZO, of at least 10 units. They have to have completed a full course of combined decongestive therapy according to the ISL guidelines for at least 12 weeks prior to screening, including use of garments for at least 12 weeks without change in regimen, and the willingness to comply with recommended self-care, consistent use of garments, and throughout the entire study duration through the 3 months follow-up visit. The exclusion criteria are patients who are incapable or unwilling to provide informed consent. They have an active infection that is currently undergoing antibiotics. They have clinically significant cardiovascular disease, digestive disease, respiratory disease, or other diseases that would affect the ability to obtain any data, any significant history of bleeding, coagulopathy, or von Willebrand's disease, an implanted pacemaker, a planned vein graft, anybody receiving chemotherapy currently or radiation therapy, history of chronic kidney disease, chronic liver disease, and anybody involved who in other clinical studies that may impact the safety, and pregnant women or anybody part of a vulnerable population. We also do exclude anybody who's over the age of 75, who's had previous lymphatic surgery, has a history of venous edema, other medical conditions or other comorbidities, and like I talked about, anybody who has current infection or cellulitis. This is what our study looks like, really. So prior to, usually consent is obtained at least 7 days prior to the procedure. Within 7 days, we obtain medical history, we perform lymph volume, we do a lymphedema quality of life measurement, we look at adverse events, and then on day 0, which is the day of surgery, we confirm eligibility again. We give a lot of details regarding the anastomosis, and then within the perioperative period, we look at details related to the anastomosis and any adverse events. also within discharge, and then we follow patients at up to 3 months, and we perform limb volume assessments, we perform quality of life questionnaires, and we assess for adverse events at each follow-up. If you want more information about this particular study, I would invite you to visit the LE&RN website in terms of related to clinical trials and the study page. You can also visit clinicaltrials.gov for any additional study information. You can contact one of the MMI reps if you have any questions related to that. You can contact the precise study investigator, the national investigator. You can also contact a study hospital that is listed, or you can visit mmimicro.com if you want to learn more about the system. So I'm going to open it up to questions, and I know some of the questions have been placed in the chat. I would ask you to please put your questions in the Q&A section. Okay, so I'll start with some of those. So a question is one question is, would the Samani help trunk lymphedema of blocked bilateral groin nodes? So I think that is a great question. So what's very important is, are we able to visualize and perform imaging techniques for the area that is supposed to be bypassed? So using either fluorescence imaging, lymphoscintigraphy, or MRI, if we're able to visualize exactly where the blocks are, then definitely we can bypass it. And frequently I use the Samani microscope to perform groin dissection and immediate lymphatic reconstruction in the groin. The next question is, what is your expectation of lymphedema incidence, as breast cancer surgery tends to be more conservative? Similarly, what is the future of robotics if the need for microsurgery decreases? So, good question. So breast cancer surgery is becoming more conservative. I think you mean in terms of axillary lymph node dissection. So if less axillary lymph node dissection is performed, then potentially we can reduce that risk of lymphedema. That is very true. I think what's most important is to understand what are the rates of lymphedema at a particular center, because it is dependent of the center itself. So in our center, we've looked at the data. We've looked at more than 17,000 patients who have had axillary lymph node dissection, and our rates of lymphedema are about 16%. Now, we haven't looked at it for sentinel lymph node biopsies, and we know that there's also there can be lymphedema that can develop after sentinel node. We also have looked at things such as radiation, chemotherapy, high BMI, diabetes, and hemoglobin A1C as actually being risk factors for lymphedema. So even if you do not get axillary lymph node dissection and potentially a sentinel node, those can still predispose you to lymphedema. Do we expect our rates of lymphedema to go down? Absolutely, we do. So what is the future of robotics if the need for microsurgery decreases? So despite, there's still over 10 million people who develop lymphedema worldwide, despite our decreased risk of axillary lymph node dissection. That's still a lot of patients, and a lot of these patients currently do not have treatment. So what I would expect, if anything, is that if we can diagnose patients early, they're likely to be more likely a candidate for microvascular surgery. The other thing that we do know is that we think that with time, lymphovenous bypasses, because they're a low flow to low flow system, actually they stop working after about 2 to 3 years. So frequently a lot of patients will require going back to the OR for further lymphovenous bypasses. And the goal is to help them plateau in terms of decrease in volume, but prevent them from an increase in volume in the future. So if anything, for the lymphedema, I actually see a bigger role. And also keep in mind that we're using the robot for not just for lymphedema, but we're using it for arterial, free flap reconstruction. Those surgeries are not going away. So if anything, I would expect that robotic surgeries will definitely be increasing in microsurgery. It also allows for longevity of the surgeon, meaning that it is more ergonomic. It's better on their C-spine. They're in a seated position as opposed to hunch over a microscope. So we also have a lot of studies related to that as well. There's another question about, do you use outside of trial subjects? Yes, absolutely. So actually more often than not, a lot of I used a robot on patients who are not part of the study. Immediate lymphatic reconstruction is not part of the precise study that I described. And I used a robot, I would say about 95 to 99% of the time for immediate lymphatic reconstruction. Is robotic-assisted surgery available for VLNT as well as LVB? So robotic-assisted surgery can be used for both. LVB is a lymphovenous bypass of a lymphatic vessel that is typically 0.5 millimeters to 1 millimeter into a venule of equal size. So definitely that's where we can use a robot. A VLNT means a vascularized lymph node transplant. That involves taking lymph nodes with the vessels that are associated with it, based on an artery and a vein. So that's like a free flap that we take from one part of the body to transplant into the affected limb. For that, we need to perform a microvascular anastomosis of artery and vein. And absolutely, we can use a robot to do the artery. Currently, we are not using the robot to do the vein because we use a coupler for the vein. How do you manage patient with predominantly fibrofatty tissue versus fluid volume? That's a great question. So I think patients who, first of all, an MRI is a great modality for looking at whether it's fat dominant versus fluid dominant. So in the context of fat dominant, a really good modality is liposuction for lymphedema. It's when we liposuction the extremity, possibly in conjunction with microvascular surgery. It is, if it's fluid dominant, if we liposuction that fluid, it's going to return, and therefore liposuction is not an option. So what I try to do is I try to do an MRI, and we have very specific sequence, and we currently have a study related to that, that looks at quantifying and qualifying fat versus fluid. And the MRI is very helpful to determine, should we start with liposuction first or should we proceed to microvascular surgery? The next question is, can you do deep tissue in the central core of the head and neck? So certainly we can do lymphovenous bypasses in the head and neck, absolutely. They're a lot more difficult to find. But deep tissue in the central core, I'm not sure that I understand what that means. But certainly for head and neck lymphedema, we can perform lymphovenous bypasses. There are very few studies related to that. There is another study sponsored by MMI who's really looking. That's looking at head and neck lymphedema. So that's definitely something that we're going to be looking at. Can you please show us pictures of the robotic? I'm not sure what that means. I showed a picture of the robot and some videos, and I showed some videos of what the anastomosis would look like. Okay. The next question. Do these patients get referred to a CLT after surgery? What is your protocol for therapists? Do patients have to continue to use compression after surgery? If so, for how long? Great question. So for all of my patients, and we've published on this, and feel free to look up our work. Catherine Bowman is the first author on that paper. I'm the last author. Our protocol is we always involve our therapist in this with our patients, all of our lymphedema patients. They have to have seen a therapist. We use prior to surgery, so when we have a surgery date, we do 3-layered compression, and this protocol was developed with a lot of therapists in Ontario when I worked in Toronto. So we do 3-layer compression for 2 weeks prior to surgery and 6 weeks after surgery. And then the goal is to transition into a sleeve or what garment or whatever they were using before, but their volumes are going to be decreased. So after that, patients have to get remeasured so that they can be fitted properly, because we expect a significant volume decrease. Having said that, the manual lymphatic drainage also changes. So instead of basically going towards the axilla or towards the groin, we do massaging towards the anastomoses to keep these open. Do patients have to continue to do compression after surgery? Absolutely. This is a lifelong disease. The outcomes are better with microvascular surgery. I don't ever tell patients that they will be cured of lymphedema because I have not changed their genetic background or their makeup. Not everybody that has an axillary lymph node dissection or a groin dissection develops lymphedema. So a lot of my research is focused on identifying what are the biomarkers for lymphedema, which patients are more susceptible to developing lymphedema. So not just risk factors in terms of clinical demographics or laboratory values or adjuvant therapy, but there must be a genetic component. So we're looking at it at an RNA sequencing level, and we're trying to find biomarkers. So when you have not changed a genetic background, therefore, I can't tell someone that they will be completely cured of lymphedema. However, with physiological techniques, it is more manageable, and patients definitely feel better. And we've conducted quality of life studies. They feel better after surgery. They can do more things, they, interestingly, and that's something that we're going to look at in more detail, they have less infections. Okay, the next question, not sure I understand that question. I'll skip over that. How many LVBs can be done at the same time? That's a great question. So for immediate lymphatic reconstruction, in the context of someone who does not have lymphedema, I try to do 1 to 2 in the axilla. Again, this is for prevention. In someone who has lymphedema, I try to do between 3 and 5. There's a lot of variability in the literature. There's a lot of studies that show that actually doing a minimum of 3 is what's considered best case scenario, but they have to be 3 really good ones, meaning the technique has to be excellent. We have to identify flow from the lymphatic into the vein. So our goal is to do a minimum of 3. Can you have robotic surgery if you've previously had debulking surgery? Absolutely. Any recommendation on surgical options for Morbihan's disease causing facial lymphedema? I'm not sure that I can answer that, but certainly we have to figure out what the cause of the facial lymphedema is. And if it's blocked veins, then typically that's very difficult to bypass. But if there's another etiology for it, I think what's important is to perform imaging using fluorescent dyes and lymphoscintigraphy to determine what the root cause of the facial lymphedema is. The next is, are we able to receive this recording? I missed the first 20 minutes. I believe so. Someone from LE&RN can give you more information about that. I'm not sure if I heard correctly. But how long does an LVA surgery last for? Did you say 2 to 3 years? Yes, you did hear correctly. So I've had some patients that I've operated on 5 to 6 years ago that are still doing well. There's more and more literature out there that shows, and I think that's because of variability of technique and also depending on the surgeons. We think that the lymphatics lymphovenous anastomoses stop working potentially after 2 or 3 years, and they have to be redone. And the reason for that is because it's a low flow to a low flow system, meaning they do not maintain their patency lifelong. And therefore, potentially it can be done, potentially it has to be done again. The next question is, can we get this surgery in Canada? So I have some information about that. I believe since I left Toronto, I know that recently they're starting another program in Toronto. There's potentially some surgeons at the UHN who are starting to do it. There's a surgeon in Halifax who does it, Dr. Andy Simpson. There's 3 surgeons in UBC, University of British Columbia, who also do it. So you can look into those centers. So I would say Toronto, Halifax, and Vancouver. How many hospitals, surgical centers have a Samani? So in the US, there's about 5 locations in the US who currently have the Samani, and we're hoping to increase that. But worldwide, and Kate, I think, is answering that question, worldwide, there's quite a few centers. Are insurances covering these surgeries, especially with immediate? The insurances have been giving a little bit of a hard time to some surgeons. However, we have developed a code now that's been approved. So the code is being used, and currently I have not had any issues getting it covered. We've also done a lot of advocacy on different levels, along with some patients who feel very strongly about it, and we have not had any issues getting it covered. Prior to the LVA ILR surgery, do you know what type of anastomosis would be performed? So not typically, no. You have to look at whether it's end-to-end and end-to-side. That's the question. So it really depends on what you find. So if you don't find a vein that is very close, or you don't find a venule that has the proper flow, then it's very possible that an end-to-side has to be done. So typically you don't know ahead of time. It's whatever you find in the area. All right, a few more questions. Any issue with significant scar in the area being a barrier to good outcomes? Yes, for LVA surgery, absolutely. So this is why it's important to also, the BMI is quite important, a BMI of under 35 to do these types of surgeries for the exact same reason. Frequently going in there and releasing a lot of the scar in and of itself will help the lymphatic vessels open up, and there would be potentially better flow. However, if there's too much scar tissue, the vessels are frequently quite fibrosed, and it's very difficult. It can affect outcomes. Canada does not currently have a Samani. Kate is also answering that question. Okay, there is one final question. Yes, are there BMI restrictions for LVA? The BMI restrictions in my practice is a BMI of 35. We have a few more minutes. A couple questions coming in again. How does radiation affect the quality of lymph nodes and lymphatic vessels? Radiation is a risk factor for developing lymphedema, and radiation increases your risk of, it can actually contribute to a lot of issues with lymphovenous bypasses. In terms of how far, it actually increases the risk of developing lymphedema by 3 to 5 times more. All right, any other questions? Okay, I think that's it.
Thank you so much, Dr. Haykal.
Thank you. Thanks everybody for joining.